And I am very, very happy to introduce Paula this morning. This is Paula Tolliver, and she's with the Central Ohio Area Agency on Aging. That's a mouthful. And Paula is the Education and Outreach Coordinator for them. And she also, I did a little research online, and I seen, Paula, where you actually participated in a document for the Supreme Court College.
I
Can you
can
tell us?
explain that if you want me to.
Okay.
Yeah, sure.
Yes, please, please. So there we are.
Okay.
There's Paula Tolliver, everyone.
So good morning. Yeah, my name is Paula Tolliver. I work part-time actually at the Central Ohio Area Agency on Aging. I work in the Family Caregiver Division, and I primarily work with families who are experiencing dementia. I also know some folks from the DD Network because I do the transportation training called Drive, and sometimes a lot of people's drivers have had me as a trainer. But in my other life, because I, only work part-time, in 2015, Derek Graham, I don't know if any of you know him, he's an attorney here in Columbus. Derek Graham and I were asked to develop the guardianship training for the Supreme Court of Ohio, which is, kind of mandated for all guardians. And interestingly enough, this particular topic came up because we developed this training kind of as a result for the some of the Supreme Court staff and also the judges, because Derek is an attorney, but he's also kind of a DD expert. So he developed their DD workshop. He has a daughter with Downs. And I am a dementia expert, and I developed their dementia workshop that we did for the state. And I have a daughter with Prader-Willi syndrome. She's 28. And so the two of us got together at one point, and we were like, we would really like to do a workshop for them for the judges on kind of that interplay between dementia and developmental disabilities, developmental disorders. We use lots of different language here in this world, but I usually use IDD if that's okay with everybody. And I usually say the word individual if that's okay with everybody. That's typically how I talk. So we actually put this, this is an hour and a half of our 3-hour workshop that we put together, which is on IDD and dementia. So Kim and Kristen asked me to come and kind of just talk a little bit about that interplay. I think I have to tell you folks that this is, research-wise, this is pretty new territory. It's only been about the last 20 years that we've really started to focus on these populations and what happens when people get to the age where they can actually develop any kind of dementia symptoms. So I'm going to talk a little bit about what we know research-wise between IDD and dementia, but I'm going to primarily concentrate on dementia itself, kind of just give you a good overview and how we see the symptoms manifest themselves in people who have IDD, what we know. I sent you 3 handouts besides, I think I sent you the PowerPoint that I gave you, but the handouts, I have to say that Europe has done a much better job at kind of starting these discussions. And so 2 of the papers, I'm sorry to say, not sorry to say, but they're not from the US. They're from Scotland and European sources. Oops, okay. And then recently, the Alzheimer's Association did come out with a nice fact sheet, but it specifically only talks about Down syndrome. That has been the most widely researched topic, is the interplay with Downs and folks who develop dementia. But of course, in the world of IDD, we work with lots of people who have lots of individuals who have all sorts of complicated kinds of disorders and may or may not be developing dementia at later ages. So I'd kind of like to take more of I'll talk about the Downs issue, but I want to take more of a whole systems approach if that's okay. I also told Kristen and Kim that I am fine with, just stop me if you have a question or a concern. I'm not a big advocate of just keeping to the end. You can also put a question or a concern or a comment in the chat box. Someone else will read it to me because I generally can't see it when I share my slides. So please just kind of stop me, because once I put my slides up, I won't be able to see you quite as well as I do now. So just kind of stop me and say, wait, I don't get this, or if you have a question. And the other thing I was telling them is that, again, this is a part of a 3-hour workshop where we talk a lot about evidence-based practice, and we make all the participants get up and actually practice some of the techniques. And so whether or not I get through kind of some of the evidence-based practice, the one thing I really put in these slides that I would really like you to, we can't practice it here because we're on Zoom, but I think understanding positive approach and hand-under-hand assistance is a very helpful technique. I have discovered where really, even in the aging world, not all practitioners understand these practices. But I would say in the IDD world, it's particularly important to understand these approaches, because we do, because they are a way to assist people who have some of the vision issues and some of the other issues that are common with dementia, without using any kind of restraints. And we're all about not using restraints with people. And so that's what hand-under-hand assistance, in my mind, is the most helpful. So hopefully I get to that. If not, it's in the slides. By the way, I put here that I'm a social worker, but I'm also a nurse. So I do both. I was a nurse first, and then my husband got transferred to Ohio. And at the time, I couldn't practice nursing because there wasn't reciprocity between Texas and Ohio. Now there is, but back in the day. So I went back to school and got my graduate degree in gerontology, actually, but I also became a social worker. So now I primarily do social work, but I kind of, I like being both a nurse and a social worker because I'm able to keep up on the medications part of things. So that's what my background is. I just wanted to say one thing about aging, and that is that, you know, the simple fact of aging is just this, you know, kind of progressive changes, right, in the physiology of the body. And we have to remember that it's both the physical body, but also the brain is a part of our body. And so our brain ages. And as our brain ages, there are normal changes with the aging brain. You know, people sometimes forget about that. And in fact, the word dementia, I call it brain failure. It's a fancy word that just means for some reason the brain is failing. It's a little bit like kidney failure, heart failure, you know, think of it like that. And so there is kind of always this interaction of typical aging symptoms. You know, we get creakier, we develop arthritis. As we get older, our brains, I'll talk in a little while about what is typical for everybody. And then, you know, when you start to see the brain display some symptoms that are not typical, but it is this kind of interplay between aging issues and then, of course, pre-existing health conditions. And so that's where we get the uniqueness. However, there are similar patterns for all adults. And I think we need to realize that, I mean, I'm talking to the choir here. You guys realize this, but I think sometimes in the larger healthcare community, there's not this realization that, you know, or this thinking that it's somehow, you know, folks with IDD somehow age differently. And they don't, they age. They may have more challenges physically because of pre-existing conditions, but people are going to undergo some of those same aging common issues, you know, arthritis, you know, things that are just pretty common for everybody. The other issue that I just wanted to kind of bring up, and we could do a whole workshop on this, and I actually do a whole workshop just on personality, behavior, aging, is, you know, there's this, sometimes again, and I'm not just talking to the IDD community, I'm talking to just in general, we have this idea that somehow people become more stubborn as they age, or they become, you know, this and this and this. And the fact of the matter is that most of us just become more of who we already are. You know, if we're stubborn, we become more stubborn because we learn more of what we like. And it becomes, if we're fearful of change, we don't just all of a sudden, you know, embrace all change and, you know, all of these issues. So, I mean, the thing is, we become oftentimes more of ourselves in that way. And that's both a good and a bad thing sometimes. Some of those behaviors that serve people very well in younger ages do not serve them as well as they become more, they might need more assistance in some areas, and people who are, you know, stubbornly independent and do all, you know, that serves them well in their 40s. It doesn't necessarily serve them well in their 60s. And by the way, I do have a slide and I want to talk about this. Sometimes the programming that in the IDD world we've planned, and very successfully, by the way, for people in their teens and 20s, doesn't really work so well as people get older. Because sometimes it's because of just the normal aging changes. But of course, when you have dementia, some of that can become a little bit more challenging. So the older we get, you know, the more we're kind of this unique combination. And that's true for everybody. Personalities and behaviors don't really change substantially over the lifetime. In fact, the evidence is pretty clear that, again, even with the onset of dementia, personality traits that people have, extroversion, introversion, some of these traits are pretty stable over the lifetime. And when we do see really significant changes in some of these, they usually indicate some sort of disease, side effects, poor environmental fit, mental health. You know, usually when we're seeing a great change, and one of the things I would say in the IDD world is this is why it's so vitally important to know people's baseline, to know how people are functioning, because sometimes the changes that can come with the onset of dementia are pretty subtle. And unless you know people's baseline, unless you know how people have been functioning before, it may be very concerning, particularly to providers who are not so, who are not as familiar with that person's baseline functioning, right? And so I'll give you an example. You know, our daughter, who's 28, her name's Emily, she has Prader-Willi syndrome. The way she functions now, actually she functions pretty well. We've had a lot of challenges over the years, but at the moment she's functioning pretty well. But if I saw those same characteristics that she displays in a 70-year-old, even as enlightened as you might say I am about dementia, I might automatically think, oh, this is indicating, you know, whatever, when in reality, this is her baseline. You know, I want to be able to compare her at 70 to her 28-year-old self, not just kind of this, you know, these symptoms are, you know, kind of, you know, so for her, I want to be able to look, and I would say that this is the importance of kind of looking at people, or at least reading people's documentation in a way that kind of says, okay, what has their baseline been over the years, and now are we seeing a change to that? Just some myths, and again, I'm talking to the choir here, but remember we originally developed this for judges who may or may not have known, you know, kind of what. So, you know, sometimes there are lifetime assumptions about lack of competency or capacity, and we all know that people, even people who we have deemed in need of a guardian or in need of assistance, do not lose competency or capacity in every area of their life. As you know, people can still make decisions very clearly about what they want to eat, what they want to do, how they want to entertain, you know. So there's sometimes in the world, though, there's these assumptions about, you know, a person's capacity. And I always say to the judges, you guys know that capacity is not all or nothing. You know, a person may not have capacity to make complicated medical decisions, but they can sure as heck tell you what they want to do during the day, you know. And so as I say, in the IDD world, we recognize this more than in most places. Of course, anytime the brain is involved in any kind of challenge, there is a higher risk for mental illness. In the IDD world, there is certainly a higher risk for anxiety, comorbidity with anxiety disorders. We see a lot of anxiety disorders. We're treating anxiety disorders in people, but this can also increase the myths about aging with IDD, because people, maybe their anxiety disorder is worsening. The symptoms are worsening. They don't have dementia, but their anxiety is continuing to get worse. This is particularly true with obsessive compulsive kinds of disorders, which are, you know, pretty common in certain kinds of folks with IDD. Automatic assumption of dementia. kind of as normal aging. This was very common in the Downs world up until about 5 years ago, because when we did autopsies, we do in fact find that 100% of people with Down syndrome at a certain age are going to show the plaque, the characteristic plaque and tangles of Alzheimer's disease. This is completely true. But as we've looked and we've started to compare the autopsies to function, we find that even though 100% of people show the actual physical disease, only about 60% of the people actually show the kinds of declines that we would associate with Alzheimer's disease. And I think this is a very, very important issue. And by the way, it also parallels the real world, or this study called the NUN study, where that's still going on, by the way. It's a very large longitudinal study, and the reason it's called the NUN study is because it looks at nuns. There are 4 large group of nuns who have been in this study for approximately 30 years, and they have all consented to be autopsied and to be extensively studied at the end of their life. And of course, we found this same phenomenon, and that is that the autopsies in about 30% of the people did not match the diagnosis. We oftentimes thought that a person from the autopsy would have advanced Alzheimer's, and we look at their function and we don't find that. And we say, you know, it was very shocking when it first came out, like, oh my gosh, what in the heck does that mean? Well, now we know that what it means is certain brains seem to be better prepared to handle the disease process. And what those brains, we think, do is they actually move function to a part of the brain that is not as affected. And so we actually see in some people, and by the way, that's where this whole kind of thrust to exercise your brain, work your brain, all these kind of things came out, you know, do crossword puzzles and all this kind of stuff, because the evidence was pretty clear that the folks whose brains were the most resilient were the folks who kind of had this delayed effect. And for whatever reason, and I don't know if it's the same dynamic, we're finding pretty much the same kinds of issues. And again, I say Downs because that's the group who has been studied the most. People with Down syndrome have by far been studied the most of any other diagnoses. And then assumption when functioning and cognitive decline occurs that it is normal aging and not a disease process. This is another piece, and that is maybe we're not so quick to look for diseases because we go, well, you know, what do you expect with this person? And it could be that this person has a disease process going on. And by the way, it could be a reversible disease because, again, or at least a treatable disease, because the other thing that can happen with folks with IDD, particularly people who have a history of seizures, is those seizures can get worse as people age. And if we can at least control those seizures more, or oftentimes we can't stop them, but if we can control them, we can somehow, we feel like the brain itself will not be quite as injured, right? And so not just saying this is normal, this happens, but also looking to the bottom of that. And by the way, I was working with a family a few years ago who had a child, and this person had autism. That was their diagnosis, and they were saying, you know, could he have dementia? He was in his mid-50s, I'd say, was definitely showing some decline and some of the typical, some of the real typical kind of symptoms that I'll get into in a minute of, you know, maybe you start to think there really is something going on dementia-wise. But he had this real issue with balance that was progressing. And finally, we actually sent him to the Ohio State University, the Cognitive Impairment Clinic, which they really are the best at trying to figure out what's going on. And we sent him there, and they found out that he had developed hydrocephalus. So he did not have hydrocephalus. He didn't have shunts. They weren't managing shunts, but he had developed a very severe case of hydrocephalus. They did do a surgery with shunts, and his symptoms pretty much went away that he had been experiencing. So again, sometimes there really is something physical going on, and getting to the bottom of that is important. Again, this is kind of, I'm speaking to the choir here, but sometimes there are real healthcare disparities. People who in healthcare who don't have a lot of knowledge and research about aging individuals with IDD, and to be honest, in the past, people with IDD, especially in the distant past, but didn't live as long. We don't have people we have never had a history of people living into their 70s and 80s. We did not have retirement programs because we did not have a large population of people getting to these ages. And so the research is not that old, is not that comprehensive, does not really look as much at the aging issues. We have a lot more evidence-based research about children with various disorders, and we're just starting to really look at, or I would say in the last 20 years, we've really started to look at older individuals. Healthcare, of course, lack of knowledge, medical history, family may not be available. As you know, oftentimes parents are still involved, and when parents get to be in their 80s and 90s, they're either passing or they're not quite as involved. Siblings may or may not have the same degree of knowledge. Health care provider, staff turnover. And then I would throw in here, in a society where material wealth is pretty highly valued, adults with IDD are more likely to be on Medicaid, more likely to have minimal income and less family support, and so may not have access maybe to the top healthcare situation, and maybe haven't had access their whole life, So I'm just kind of throwing that out there. Okay, questions before I go on. I do want to talk about what we do know about both Downs, CP, the three areas that have been the most heavily studied. And again, it's just a drop in the bucket. We need a lot more research, but we do have a fair amount of research on Down syndrome. We do have a fair amount of research, at least we're getting there, on cerebral palsy. And also we've started, and now there's more research coming out every day on autism and dementia, or just aging, but how that kind of can impact or be. Anybody have any questions or comments first? Okay. So Down syndrome and aging, again, the most studied at this moment. Of course, we know that people with Downs are at higher risk of congenital heart disease. This is very well documented. Earlier onset for risk factors, particularly diabetes. We find that, and it tends to be type 1 diabetes as opposed to type 2, which is more challenging. In the general population, the risk factors are more for type 2 diabetes as people get into their 40s and 50s. And we find that for people with Downs, it's type 1, which is always going to be insulin dependent. And we'll talk in a minute about the higher risk for Alzheimer's disease, which is certainly there. Of course, all of us know that people are at higher risk of adverse side effects of medications. Anybody really with a complicated health situation, and heart disease and diabetes and everything, can just complicate the way medicine works in people's bodies. And part of the problem with folks with IDD in general, but Downs specifically, is the body really doesn't always process medications, particularly psychotropic medications, in the same way. And so we're kind of, it's kind of an experiment. We're given a little bit of a medication, very low, we go slow, and then we see, is that going to have an adverse effect or not? And if not, so medications are more complicated. And by the way, medications in people with dementia in general are more complicated because brains degenerate in different ways and in different fashions. Hearing impairment, of course, increases. By the way, people with Downs who have hearing impairment, which may be, lifelong, you definitely see an increase of all hearing impairment with age. In fact, in a person without any kind of intellectual impairment or anything, the chance of being hearing impaired at age 75 is about 80%. So the level of hearing impairment for everyone increases with age, but this seems to be particularly profound for people with Downs. We do, for whatever reason, find adult onset leukemia more common. And then, of course, people sometimes struggle with either autism, struggling with that filtering mechanism in the brain, or some of those tendencies. So close to 100% of adults with Down syndrome exhibit the plaquing. So when we do autopsies, particularly of people in their 50s and 60s, starting in like the late 40s, when we do autopsies, about 100% of people exhibit the typical plaquing and neurofibrillary entanglements. So we call these plaques and tangles. And there is a protein called the tau protein, which is the primary protein or the primary chemical in Alzheimer's disease that causes the plaques and tangles. And this is a protein that facilitates communication in the brain. And so Alzheimer's disease, at least one type of Alzheimer's disease. Now you have to remember that at the same time we're looking at IDD and dementia issues in the research, we're also learning a lot more about dementia in general. And so we used to think everything was Alzheimer's, and we know it's a much more complicated picture. And even within the Alzheimer's diagnosis, there are probably at least 7 different kinds of Alzheimer's disease. And probably every single one of them is genetic. We just haven't done a very good job of really identifying that chromosomal link. Part of the challenge, of course, is that most of us don't even know if we have Alzheimer's in our family, because people die of heart disease before they get old enough to get Alzheimer's disease. And the same, by the way, with Parkinson's. Parkinson's and Alzheimer's are two diseases which in many people, or many different types of these diseases, only start to show symptoms in older ages. And so, but having said all of that, the early onset Alzheimer's disease is definitely associated with chromosome 21. And so the amyloid precursor protein, the APP, we sometimes call it, it's the same chromosomal abnormality that causes Down syndrome. It also can cause one form of Alzheimer's disease. And as I said earlier, however, we would surmise, and for several years there, people were saying 100% of people with Downs get Alzheimer's, which by the way is true. But the question becomes, how many of those folks display the symptoms?
Hey, Paul, I have a question.
Sure.
In regards to the chromosome 21 and early onset for folks with Down syndrome, do they find that that's a fast acting progression?
It is.
Okay.
So of the 7 different kinds of Alzheimer's disease that we know of, or that we have identified, the fastest, the young onset is by far the most progressive. It's the most quickly progressive. Now remember, we're dealing with the world of Alzheimer's. And so when we talk about quickly progressive, we're still talking about 5 to 8 years. Okay, so we're not talking about, when we think quick, sometime we may think pneumonia, 3 weeks, 4 weeks. No, we're talking still, it's a long-term progression. Okay. Yes. And by the way, and this is a sad fact, and I'm so sorry to say this, but Alzheimer's disease is a fatal disease. It's fatal every single time. It's fatal all the time. We do not have a way of preventing it. We do not have a way of curing it. We do not have a way of stopping it. So I can say with 100% certainty that every single person that we know of at this moment with Down syndrome, or at least everybody in the studies, we have 100% on autopsy. We find in people over the age of 50 with Downs, we find evidence of Alzheimer's disease. Now, whether they actually die of Alzheimer's disease or not, they may die of something else ahead of time, because Alzheimer's disease destroys the brain. And as it destroys the brain, people die of pneumonia, people die of many other things. And as I say, this is a very sobering fact, by the way, for families. And so what I like to say, though, again, not to be so, because people say to me, what do you mean it's a fatal disease? And I say, Alzheimer's disease is a fatal disease. It destroys the brain. It's just that in most people, and that would include people with Downs, it's a slow acting disease. It's a faster in people who have the young onset version, but we're still talking 5 to 8 years, maybe even longer. But what I do say with this is, by the way, that's why I would argue that all of us who are in the IDD world, which I consider myself because I've been an advocate mostly with Franklin County, not in Fairfield County, but for my own daughter, we need to be advocating strongly for dementia research too, because, you know, this is a big issue. Not only, you know, it's a big issue, and I'm happy if we find a vaccine for this horrible coronavirus, but I'm the one out there saying, could we still put some money, please, into this Alzheimer's issue and all the different forms of dementia, you know, because they are definitely killing people. It's definitely a fatal diagnosis. It's not a diagnosis that is like, well, you know, they might just die of it at some point. It's like, no, it will kill them. It will destroy their brain. It's just a matter of when and how long that's going to take. However, I say that not to be super depressing, but also to say that there is hope here in the sense of people's function. And one of the things that was, as I say, a big surprise was when we finally started connecting those autopsies to function with people with Downs, we were like, oh, wait a minute. This person from their autopsy has advanced Alzheimer's disease, and yet we're not seeing as much of that in function. Okay, so so longitudinal studies indicate that about 60% of people, when they are autopsied, their brains match their function. Okay, and by the way, that parallels the general population too. In the general population, if we were going to do autopsies on everybody, when it comes to brain disorders and Alzheimer's and things, again, we have this really strong evidence-based NUN study which says, wait a minute, there are all these people that have serious cognitive declines going on in their brains, and their function is not reflecting quite that point. You know, I'm not saying they're completely functional and they don't show any decline at all in their function, but it's not as advanced as the brain would make it appear, if that makes sense. Okay. So it is a major system issue, as healthcare providers, advocates, families don't really understand this, and it has almost become this automatic assumption of Alzheimer's disease. And then people don't look for other see, if someone who is 65 or 70 or young, you know, starts to develop some of the symptoms of Alzheimer's disease, the first thing we're going to do, a neurologist, a good solid neurologist is going to do, is look for everything else that can be causing those symptoms. Going to look for thyroid disorder, going to look for hydrocephalus, going to look for, because there are other kinds of things that can cause those kinds of symptoms. And so we would advocate that that happens also with folks who have Downs. Don't just automatically say, you know, this person has Alzheimer's disease and that's what's, you know, look and see, do they have other conditions? Okay, I'll come back to kind of the dementia issue with that in a minute. Cerebral palsy has also been studied pretty extensively. And the one thing I would say about cerebral palsy, of course, is people, as you all know, people with cerebral palsy, their symptoms vary obviously very widely, you know, and there's not always any intellectual disability at all with the condition. However, people often start with very impaired bodies because the condition itself, you know, has so many physical manifestations often in people. And so this obviously is a concern, because when eating and swallowing becomes an issue, then people's nutrition becomes an issue. And one of the things we find with aging with cerebral palsy is eating and swallowing oftentimes becomes a much more difficult issue as people develop arthritis and as people's, you know, scoliosis, obviously people's lung condition deteriorates oftentimes because of their muscular issues, and so that can result in less oxygen to the brain. Tuberous sclerosis, Medications we already talked about. Arthritis and osteoporosis, for whatever reason, in people with cerebral palsy does tend to be more quickly progressive and oftentimes more debilitating, probably because of all their other issues. People sometimes who have not been in a lot of pain, probably because of the scoliosis and arthritis, are all of a sudden in a lot of pain. And pain, you know, pain is pain, and it makes it certainly can cause mental decline, or this kind of not ability to react in the same way. And then, of course, respiratory issues. Again, the body kind of all works together, and the brain is an organ. So we haven't done tons of research on cerebral palsy and dementia, but the early indications are that people with cerebral palsy also have a higher degree of mental decline or brain decline. There doesn't seem to be any higher development of Alzheimer's disease itself. It's really more what we call vascular dementia with people with CP, and that is their over or cardiovascular and vascular function declines, and that causes the corresponding decline in the brain. And then I just wanted to mention autism. People with autism typically, as you know, are people on the spectrum. Autism is a very complicated beast that we really have never understood very completely, and we still have lots of research to go. But people with autism typically have very typical kind of physical bodies that don't necessarily have some of those comorbidities that maybe some of the other folks do. However, one of the things that we're studying a lot is there may be some possible predisposition for neurological impairments, and one of those would be Lewy body dementia, which is a form of Alzheimer's disease that hits the middle part of the brain and kind of moves outwards. And so there may be some predisposition because of just the kind of the predisposition. Again, that's very early. Lifestyle, people with autism oftentimes or on the spectrum have difficulty adjusting to changes, loss of routine. People may or may not have healthy social networks out there already, and now they're exhibiting some aging symptoms. Life stressors, including sensory overload and demands, especially as people maybe have to move into a different kind of living situation than they've been accustomed to. And then, of course, environmental changes, and this would be hearing and vision, which are very common in all older adults. There is evidence that people who with certain, especially on the autism spectrum, have a greater challenges when it comes to adjusting to environmental change, but also vision and hearing issues. When people really do start to develop, because people with autism can also develop Alzheimer's disease, but the hallucinations and delusions tend to be more scary. They tend to be more profound. We're not really sure why that is. Again, all these areas we're just really touching the surface. Okay, questions about that? I want to just, before I talk about the symptoms that we tend to see and just kind of be on the lookout for, I wanted to just kind of talk about some typical memory changes. In fact, you might have even seen these happening with yourself and been concerned, like, oh my gosh, what's happening to me? Like, I do lots and lots of dementia assessments, and one of the things I say is the person who comes to me with the list of all their symptoms and says, Paul, I think I'm getting Alzheimer's disease, here's all my symptoms, is probably the person who doesn't have Alzheimer's disease, because it's not typical for people to actually remember what they forget. And that seems weird, but but it is typical for people as we get older to start to be concerned about our memories in particular. And so two things happen pretty much to everybody, all of us. And, folks with IDD, interestingly enough, folks with IDD don't actually experience as much of these challenges. I'll talk in the next slide about some of the challenges that we're actually more likely to see. But short-term memory tends to shrink for all of us. And so what we call working memory, it's on, and I know this is my right, but I always, I'm looking at you, so I'm going to say left. So in the left temporal region is working memory. And whereas our working memory over our lives can hold about 15 non-related items, as we get older, it goes down to about 5 to 8. And so what happens is most of us, as we get into our 50s, 60s, and 70s, we start to make ourselves lists. We start to develop patterns where we put our phones, where we put our, glasses, and we start to kind of do these pretty automatically, because what happens is our working memory just decreases. And so we start to find ways to kind of build that up. And so how many of you have ever gone into a room and you want to do something there, but you can't remember what it was? So you backtrack, and you try and kind of reconstruct. And how many of you have lost your car in the parking lot, or put your glasses someplace and now you can't remember? So this working memory tends to be a challenge for everybody as we get older. And the other issue that happens is we just have more information here in our brain. I always call this the file cabinets get more full. And so what happens is we look at people and we know them, but we don't know where they're from. I mean, we can't place them. And so we're like, and we can't remember their name, which is super embarrassing. And then 2 hours later, it all pops out. You're like, well, thank you very much. I wish you would have done that too, And so we say, there's something going on with my memory. It's just, I'm just having a really hard time. The more stressed we get, the more these two areas become more challenging. And I say that to say, these are pretty typical, and these are not, if people are just exhibiting these symptoms, they're probably not exhibiting the typical kind of dementia symptoms. And again, these are two symptoms that we actually don't see as much in folks with IDD when they're actually experiencing brain deterioration. Okay, so dementia is both. When we say the word dementia, we mean both the chemical changes in the brain, and this is primarily having to do with the tau protein, or at least the communication within the brain. When we say vascular dementia, we're talking about when the vascular system, when people are having little strokes and there's blood that's not connecting, okay? So when we talk about dementia, we're definitely talking about a chemical change in the brain. In fact, sometimes I liken it to the highways are blocked. So the communication has to turn and go another way. It's constantly being rerouted, because those communication, those cells are dying, and so the highways are kind of blocked, okay? The more highways that are blocked, the more symptoms that people tend to have typically. But there's also a structural change in the brain, and as the brain dies, it shrinks. Okay. And so one of the things we see when we do scans, which we do, by the way, and the scan that you probably want to have people request, I mean, just to say, when people go for comprehensive assessment, which I absolutely recommend that people who are showing some of the symptoms we'll talk about in a minute go and have a comprehensive assessment by a competent neurologist who works with dementia. Some of the folks who work with seizures know dementia too, but a lot of times people with IDD do have a neurologist, but they have a neurologist for seizures or for, and so really kind of do some homework. But when we do the scanning, CT scans and MRIs will focus on soft tissue and hard tissue, but they're not going to focus on the chemicals. And so and they can tell us something. So those will typically say something is shrinking. So oftentimes when people have had either an MRI or a CT, they're going to come back and say, wow, we see in the left temporal region, we see some shrinkage in the tissues, okay, which is going to indicate something's going on that's shrinking those tissues. But the scan that we like to ask people to get is called a PET scan, PET scan. And the PET scan actually looks at the chemicals in the brain and where they're going and where they're not going. And this scan actually is a better indicator of what's actually going on in the brain. And so we will typically, especially for people with pretty complicated health situations. Because PET scans, the insurance companies, particularly Medicare and Medicaid, will cover them, but you oftentimes have to have a neurologist doing you can't just, your normal family physician is probably not going to be able to have the person. The other thing that's nice about a PET scan is for people with IDD, they're oftentimes less scary and less imposing than the CT and the MRI. MRIs are scary for many people. You have to stay still, and you're, going into this kind of scary kind of place. And again, PET scan is this, so for some people, this is not as challenging. They are getting injection. Again, shots can be scary, but they're getting an injection and they're looking at the chemical, the heat sensors of the chemicals in the brain, and it gives a good indication. I meant to put in a slide in that shows you what PET scans look like, because what they do is they show up as color and they show up as where the chemical activity is going on in the brain, and it can sometimes indicate. But the other thing about dementia is, especially when only parts of the brain are being destroyed at the moment, sometimes it comes and goes for some people. And this is maybe one of the most frustrating aspects, is that, people can have good days and bad days, and they can have days where they are hallucinating like crazy and just really having a very difficult time, and they can have the next day where they're pretty clear. And this can happen particularly early in the disease processes. Dementia equals brain failure. For whatever reason, the brain is dying. Now, this is how we typically teach dementia, not just dementia IDD, but dementia. We talk about dementia as an umbrella, and the umbrella means brain failure. And then there are all these different causes. So a good competent neurologist, what they're going to do is they're going to look for any of these causes. Okay, they're going to take the causes that are reversible or treatable, and they're going to identify those early, and then they're going to look to see, what else might be causing it. And so Alzheimer's disease, under here we put young onset and late onset. Again, there's probably other variations attached to other chromosomes, but these are the two that we're pretty clear about. We typically will divide it. Folks with Downs are pretty much going to develop the young or early onset, young onset form of the disease. Vascular dementia, we will sometimes also call multi-infarct. Other people, and again, people with CP are the ones who are the most easily identified, because they have so many vascular issues oftentimes, and respiratory issues, are more likely to develop vascular dementias, which is when there's the blockage in the brain, and the blood's really not getting to that area, and that area tends to die. The thing and you say to me, Paula, why differentiate? Well, the interesting thing, and sometimes it doesn't make a lot of sense to differentiate. If I'm working with a 90-year-old person who's showing signs of dementia, I'm not going to care so much if it's vascular Alzheimer's disease. I'm just going to try and, figure out what their symptoms are and accommodate and really kind of make them feel not scared, because the world becomes a scary place. That's the thing about dementia. People say, oh, people get aggressive and assertive and all this, and they are violent. No, they're not. They're scared. That's what happens, because the world becomes a scary place for people. In fact, the evidence is that some folks with IDD, actually, the world has always been a scary place for them. And actually, the onset of dementia sometimes quiets down some of that irritation, or at least it changes it. And so people have kind of some changes. Anyway, but vascular dementia is not very predictable. It goes like this. People can be at a plateau and then they can decrease overnight. Alzheimer's disease, and early onset in particular, young onset, goes like this. There's always going to be decline. The decline is slow, but it's also very predictable. People decline at a pretty predictable pace, okay? So in younger people, I always want to know the difference, because it really does help families interact with people. If it's vascular, there's going to be a lot more unpredictability, whereas with Alzheimer's. Lewy body dementia is another disease process that we seem to find might be more common in IDD populations and has not been well identified in the past. Lewy body dementia is a disease that happens in the middle of the brain, and it moves out and it destroys the brain. And people have both Parkinsonian symptoms. So a lot of times they have the stiffness and the tremors, but then they also have some of the cognitive symptoms, but it's the front of the part of their brain that deteriorates first. And so people with Lewy body dementia oftentimes have almost psychotic symptoms. And I'll give you an example, and you guys might have heard of this from the news. So Robin Williams had a complicated brain. We can all agree with that. He had suffered from some mental illness concerns. He had had some, drug issues over the years. He had a complicated brain. But when he started to really show some significant stiffness and even developed a tremor, I have to say the docs missed it. And so what they did was they treated him for a traditional Parkinson's. And the problem with that is Lewy body dementia does not respond well to those typical treatments. They just really didn't look too far. They diagnosed him with Parkinson's, they treated him, and it sent his medical condition way down. And after he died by suicide, they did the autopsy and they found out he had Lewy body dementia. Now, if they would have identified that he had Lewy body dementia, they would have treated him very differently. I'm not saying it would have prevented his suicide, but you never know, really. And so that's why Lewy body dementia is really, really important, because we also find that the medication that we're typically going to use for like Parkinson's, we have to be super careful with folks who have Lewy bodies. We're not going to probably use the same kinds of medication for those folks. Another disorder is frontotemporal dementias. And again, we used to think that frontotemporal dementias, which always hit the front of the brain, it's like Alzheimer's that hits the front of the brain first. We used to think that these dementias were so rare, we hardly ever saw them. And now we think that they're probably about 20 to 25% of brain decline. And particularly frontotemporal dementias do not manifest themselves with memory probably till very late. They manifest themselves in terms of behaviors. We see all sorts of behaviors. In fact, I have a friend in Detroit, and her husband started exhibiting, he was a Vietnam vet, and he had started exhibiting all of these really bizarre behaviors, including removing all their money and doing all these things. And she ultimately had to divorce him to protect herself. And now only years later, he subsequently developed what they called Alzheimer's disease. When they did an autopsy on him, because it was enrolled in a study, they found out that he had frontotemporal dementia and probably had it during those years where his behavior was completely erratic, And for her, I feel like that's helpful because it explains a little bit for her. It didn't help him any because, so frontotemporal dementias. And then, of course, I put over here all these other things that can cause dementia, including, by the way, if people have a sudden onset of symptoms, we're always going to look for urinary tract infection. Always. We're going to look for urinary tract infection because urinary tract infection can cause this sudden onset. So any Alzheimer's disease and all these other dementias, they are not sudden. They're insidious. They're relatively slow. And they're progressive. But if there's a sudden onset, we're going to look at medication interactions, and we're going to look at urinary tract infections typically. Sometimes we're going to look at dehydration too. If we have kind of this sudden onset, we're going to be looking more for that. Does anybody have any question about that? You hear my Christmas clock going off.
Hi, how are you today?
Good.
Good. This is April with the Bentley Transportation. And I just have a real quick question because I wanted to reflect back to the cerebral palsy part of it with Alzheimer's disease. If I understood right, I know you were mentioning about Down syndrome, but do the cerebral palsy individuals typically get or have Alzheimer's disease? Is that what I was understanding?
People with cerebral palsy, typically what we're seeing with them is not Alzheimer's disease. What we're seeing with them is vascular dementia. So again, could they develop Alzheimer's disease? Of course, if they live long enough and they're genetically predisposed, which again, we're learning. But if we're looking at something early onset with those folks, we're typically not looking at Alzheimer's. We're typically looking at vascular dementia. Now, you say to me again, Paula, how does that different? Well, it's different because Alzheimer's, again, is progressively progresses. And vascular dementia can vary very much depending on people's respiratory and cardiac function. Okay, so it could be that someone with cerebral palsy has a respiratory event or some event that ends that they end up in a hospital even, or maybe they're on a CPAP machine and they take a week off and all of a sudden they're having all sorts of respiratory issues, things like that. You can actually see some cognitive decline. That's actually more common with those folks, is the vascular dementia, because of all the respiratory complications that often are part of cerebral palsy.
Okay, I got it. That makes more sense to me. Okay, that's all I wanted. Thank you.
Mm-hmm. So again, it's a complicated picture. I don't pretend to tell you that it's really easy, and it's just, you know, we're learning more as we go. Dementia itself is complicated. And then we throw in kind of IDD diagnoses, and sometimes, you know, again, I would say the biggest problem I have with IDD is people actually aren't looking for dementia. They're saying, well, that's just typical with that person. And the question I always have is it really? You know, is this different from their baseline functioning? You know, so because dementia really is brain failure. I already mentioned all of this. It's a symptom, not the diagnosis. Typically, we're looking to see what might be causing it. Onset is typically slow. We're always going to look, hopefully, for reversible factors, treatable factors, and then there are irreversible factors. The medication, by the way, and I don't have a slide on this at all, but let me just say the medication that we currently give people who have Alzheimer's disease and even vascular dementia, we will give it. Is a medication. There are two types of medications. There's actually three medications. There's two types, Aricept or Exelon, which is one type. And then there's another type called Namenda, which we will sometimes give to folks. These medications do not stop the disease process. They do not cure the disease process. What they do is they help the brain function a little bit better, despite the fact that the disease is moving in the brain. I will tell you that pretty much everybody with Down syndrome who's developing signs of Alzheimer's are going to end up on probably an Exelon patch. And later on, and we do see some cognitive increase sometimes when people are on, but again, it's always complicated because these medications oftentimes have cholinergic effects or digestive side effects. So we watch them closely, you know, but have we seen an increase in function on those medications that we give? Yes, we have. Yes, we have. So a neurologist will still start people on either Exelon or Aricept typically, and possibly Namenda later on. Okay, so I wanted just to go over the symptoms that you might be seeing, or the symptoms that are very, very common in dementia. Any really, you know, different things that can cause dementia. Some of these symptoms are more profound, but I also wanted to mention what we do know about folks with IDD and kind of how these manifest. So part of the problem, I think, with talking about dementia is we focus so much on memory, and short-term memory in particular. And the fact of the matter is that dementia and anything that causes your brain to fail is going to have a lot of other symptoms. And in fact, one of the reasons I would argue that we sometimes miss the early signs of dementia in people with IDD is that the evidence is pretty clear that short-term memory is not an early symptom for folks. For folks with IDD, it seems to be a later symptom. People seem to develop other kinds of symptoms that we could be on the watch out or the lookout for. So having said that, part of short-term memory, the challenges is the fact that people do what we call get lost in time and place. And so what that means is as the outside of the brain is deteriorating, and this is where our short-term memories are, the middle of the brain is pretty good, and so long-term memories tend to stay pretty good. And so people will take their memories and the longer-term memories, and they'll bring them out to the surface and use them to interpret today. So people will think that their parents are still alive, for example, but the parents they remember are not the old people that they live with. They're young because it's earlier memories, right? So people will, what we call, do a little bit of time traveling. And this has been very much mischaracterized in the news as kind of second childhood or all this kind of stuff. No, it is not a second childhood. And just like in IDD, people don't appreciate being treated like children. And we've been very strong about that, you know, treat people the age that they are. With maybe some, you know, practical applications of the way we use language and things. But with dementia, we sometimes will see this time traveling element. And so people are misinterpreting current events by using past memories. People will think their brothers and sisters are their, you know, if they do have children, their children are their brothers and sisters, things like this. The other thing, which is very common, is getting lost in place. So what does that mean? That means that people start to have trouble kind of getting around the world. If they're driving, they're getting lost while they're going to places that they've always been to. We actually don't see this again. We don't see this as much in folks with IDD, and I would argue that sometimes part of the reason is that folks with IDD have oftentimes been very tuned in to local landmarks, the way things, you know, the way I get someplace, people are maybe more tuned in. And so maybe this symptom just doesn't manifest itself. Now, in someone without IDD, this is a very early symptom. In fact, you know, one of the things I always ask families is, are people getting lost? And by the way, people don't tell you, they don't come home and say, hey, I got lost on the way to the grocery store, but they just don't come home for 2 hours. And then they come home and you go, where have you been? And they go, what are you talking about? I'm fine, leave me alone. You know, and so it is really, really common early in any dementias for people to kind of get lost in place. And this can even happen in people's houses and in people's, you know, people get lost. They can't find their way to the bathroom. They can't find their way to the kitchen. They go outside and they always take the same route. And now they're turning the wrong way. And now they keep, you know, and so it's really common for people to kind of get lost in place. A very common, and now body sensations, I have to say, this is newer research, but we are finding in IDD populations that this is very much manifesting itself. And it's a very interesting concept. For the longest time, we thought that people with dementia didn't feel pain in the same way. And the reason is because people have, the way they experience pain, particularly in their extremities, changes. So people can't tell you where it hurts or how much it hurts. They just moan. They don't have the ability sometimes to articulate what's going on. And we now know that people do experience pain. We just don't interpret their symptoms in the same way. We think, oh, they're moaning or they're crying or they're irritated, and we're not doing a very good job of interpreting that. At the same time that's happening, though, the way the brain is deteriorating, particularly with Alzheimer's disease, is that certain parts of the body start to become hypersensitive. Anybody want to guess what those 4 parts of the body are that are hypersensitive? I put my hands out for this reason. My mouth. The whole mouth region and the throat. So people experience this hypersensitivity, and all of a sudden, and if you notice people all of a sudden or just start, they don't like warm food anymore. Now, there are people in this world who never liked warm or hot food. They always like cool food, right? But people who like sweet and cool. Sweet and cool. Because what happens with the mouth is the mouth becomes hypersensitive and the taste buds start to deteriorate except for sweet. And so we find sometimes that people are not just liking, but really kind of craving, okay? So the hypersensitivity in the mouth, in the hands, the palms of the hands, the bottoms of the feet, and also in the genital area. So it is not uncommon for people to be really hypersensitive in the genital area, not want to take showers, not want to take baths, not want to, because people become super cold and now it's uncomfortable. And so we start to have what I call the shower wars, you know, the battle, because people don't want to take their clothes off because it's cold. And also there's this hypersensitivity in the genital area, and we don't really, you know, we haven't been so tuned into that as we could. Another really common, and I'm going to take my glasses off to show you what this is like. If I was in front of you, I'd make all of you do this. Very, very, very common in all forms of dementia. We absolutely see this in people who have IDD, is this, this development of what we would call a tunnel vision. Okay, so side vision goes away and people don't have vision above and below. Okay, and so again, this is kind of insidious because no one's going to tell us, hey, wait, something's going on with my vision. It's just that it's kind of insidious. What we notice is people, when they, if you do this and you look down, this part of your food doesn't show up. So we start noticing people eating only part of the food on part of their plate. We start noticing people having trouble grabbing utensils when they've been able to do it in the past. We start notice that people start tripping over things that are outside their visual field, like coffee tables and throw rugs, where they've been able to navigate really well, because, you know, without a dementia, we scan our environment and we kind of look and see what's ahead of us. But as dementia sets in, again, we end up like this. And so I say this to say also this has an implication for care practice, because as people develop this kind of tunnel vision, as we lean over to assist people, we don't always realize that they're not looking up and seeing our face, they're seeing our chest. And now we try and touch them, or we, worse than ever, we come up behind them and touch, or touch out of visual space. And, you know, one of the things, and this is really an important concept, which again, we just have really started to focus on in the last 5 years, is understanding that because of these visual changes, we have to be super careful to be in people's visual field and not talking to people from behind, not being on the side and assuming people know, you know, being really as much as possible. And before we would ever introduce any form of touch to assist people, we're in the visual field and we're, you know, we're comfortably within people's visual field. Okay, another one, and this, you know, is a pretty frightening for most families. And again, has someone with an IDD diagnosis ever had hallucinations and delusions? I don't know. People are all different. Typically, people with IDD do not have hallucinations and delusions, unless maybe people, you know, if people are intoxicated or whatever, because sometimes these can come, but it's not a typical, it's not so typical. Now, it is typical with certain mental illnesses, and if you have some sort of a dual diagnosis, bipolar disorder can have delusions and hallucinations. Schizophrenia can certainly, and certainly almost does. So hallucinations is actually sensing things that are not there. And delusions are believing things that are not there. When the brain deteriorates, I will tell you that almost every brain starts to experience delusions and hallucinations. Okay, when the brain deteriorates, people, it is a very, very, very common symptom. And the other common symptom is that people, the delusions and hallucinations are completely real to the person. The person completely remembers that they are an adult. And if you try and correct people who are having hallucinations and delusions, how does that go? Anybody want to unmute and answer me? How does that go? You try and argue with people or correct people.
It exasperates the situation, I think.
It absolutely does. It absolutely does. And so one of the things that I say, and I train this all day long when I'm training families and care providers, is I talk about the fact that when people are having hallucinations and delusions, the absolute wrong thing to do is to argue with people, use logic with people, try and argue people back to, quote, reality. And one of the things I say, and people say to me, well, Paula, it feels like I'm lying. And I'm like, you know what? If someone thinks that I'm their mother, is it really kind and compassionate to continue to tell that person, your mother's dead, she's been dead for a long time? We may say it in a kind voice, but it is not kind, okay? So it's really okay to do what we call get on the bus and go where it's going. And it's really okay to say, wow, she's not here right now, or just to ignore it and go on and change the topic. And I mean, because also when people are having hallucinations and delusions, oftentimes it's a reflection of being scared because the environment is scary. If I see shadows coming in my bedroom window and my brain interprets that as shadows coming in on my bedroom window, okay. But if I see shadows coming in and now my brain is impaired and it's thinking that people are coming in to hurt me, is it really helpful for someone to say, now they're not there, you're really not seeing that? No, I want someone to say, wow, that must be scary. Okay, what can we do? Okay, so what we typically will tell people is just get on the train and go where it's going. And the best responses to people are affirming. Wow, that's really scary. Wow. So and one of the things, you know, people think I'm their mother all the time. I don't know what it is about my glasses, but I always say, hey, so tell me about your mom. What was she, what is your mom like? You know, what do you like about that? Again, I'm not going to pretend to be something I'm not in the way that just encourages people to be more scared, but I am certainly never going to argue. I'm never going to correct. And that's one of the things you can kind of help your staff with, because I think what happens is we want people to be grounded in what we call reality, and we don't always realize that the brain, as it deteriorates, the world becomes a very scary place for people. And so it's really okay if someone's saying people are coming to steal from me, to say, wow, that must be really scary. And really talk about what you can do to stay safe. And then divert the person by saying, hey, what would you like to drink? Would you like this or this? You know, so people are oftentimes easily divertible, but also when they feel listened to, when they feel affirmed. So, you know, we could go on with this, but emotions for people oftentimes become more volatile because oftentimes the front part of the brain is being attacked. Now, let me just say something about the right side of the brain. The right side of the brain in most of these disorders stays pretty good. The right side of the brain is music and rhythm. The right side of the brain is also ugly language. And so one of the things that can happen, and this is particularly interesting, I don't know, interesting, but particularly in people who don't have much of a filter to start with, they don't have any filter now. It's gone. And so people will say, wow, you're really fat today. Or reach out and touch you, or touch something that looks interesting. And people are like, what is that about? And I say, well, the front part of the brain, which is the filter, is gone now. It's been affected by the disease. It might have been affected by the person's earlier disorder, particularly, you know, certain kinds of disorders have less of a filter because the frontal part of the brain's a little bit more affected. But now that filter oftentimes is gone. And so people will use ugly language, they'll use cuss words, they'll use offensive language. And we got, again, you have to realize that that's kind of part of the disorder. People will say to me, my mother doesn't even know those words. And I'm like, well, no, she knows them, but she never used them because she learned the rules, you know, and in the autism world, we're big on teaching people rules, so, and people will follow rules. Well, now when the brain doesn't process rules anymore, you know, and people get irritated and people get upset. And by the way, people with these disorders will get irritated and upset, and they will stay irritated and upset even when they don't remember what they're irritated about or who they're irritated towards. Because the emotions, those part of the brain, the emotional volatility is basically on the right side of the brain, and the filtering aspect, which kind of walks us through and says, is that logical? Is that, you know, that kind of logical? That's what's been destroyed. Another issue is language. Now, we oftentimes work with people who already have language challenges. And so I would say in the IDD communities, oftentimes it's looking for changes in language issues. Okay, so people who have a range of language and now their range is getting smaller, or people who are really not responding to questions and they were able to in the past. Or, you know, the other thing about language is I oftentimes say, and again, we do this pretty more effectively in the IDD world, and that is have people show us, because people already are having some language issues. Oftentimes I'm telling people outside the IDD world, you know, the best words you can use with someone who's really frustrated because they're trying to get their message through is to say, show me, show me. Don't put words in their mouth, just say, show me. And I oftentimes find that in the IDD world, we kind of already have some of those behaviors in terms of interaction. But I would say in general, be very watchful of the way people are using and understanding language. And if you start to see a real decline, this is probably an indication that something's going on with the brain. Decision-making, judgment, problem solving. I always laughingly say that, you know, older drivers are actually the safest drivers. And even, you know, some people with IDD drive too, are the safest drivers because they take themselves out of dangerous situations. Older drivers with dementia are the most unsafe drivers because they will put themselves right in the middle. So if you start noticing that the person is putting themselves in kind of the middle of dangerous situations, and that really wasn't their pattern in the past, that would be a red flag for you. People who are, you know, doing things that are just kind of like that, you know, opening windows in the middle of winter, climbing out, walking in barefoot, you know, out in the cold, or, you know, these kind of things are sometimes indications like, wow, you know, what's going on here, because that logic part. And then the last one, of course, is insight. So most of these issues where people are developing brain disorders, they just don't have insight. It's just not there. People don't know they're sick. They don't necessarily know that they might, you know, people have insight oftentimes into IDD conditions, and they're can tell you, but with dementia, really, there is this profound lack of insight. So people think they're fine. And so we try and argue with people and say, you know, you have to go to neurologist because your brain is sick or whatever, and people just don't get it. And so one of the things that I always say to families, and this is true in the IDD world, is you need to know that people are lacking in insight, and you don't make it about their illness with their brain. If people have a pain in their leg and their leg hurts all the time, make it about that. Figure out what people are concerned about in terms of their own body and make it be more about that. Because to try and convince people that people have a brain disorder That's just it. For most people, there is just not a sense of insight. Now, I wanted to kind of mention what remains intact, and then on the end of the presentation, I have a bunch of just, as I say, evidence-based practices. The reason I always like to say what remains intact is that if we don't kind of understand this, sometimes we don't have the tools we need to really help people continue to function well. And so some things that are really located for most people on the right side of the brain and are very helpful in terms of kind of, using automatic social responses. Oftentimes when folks, especially folks who with IDD, have learned the rules and have kind of learned, I'm polite, I put out my hand, I do these things. And even when people can't articulate those, anything that people have learned much earlier in life, oftentimes people can still do. So people can still sometimes do chit chat if they could do chit chat before. Sometimes you put the fork in someone's hand and they know exactly what to do with it. Sometimes you put the toothbrush in someone's hand and it's the automatic response. Those automatic social responses, long-term memories and skills, oftentimes we can use those when people have deficits in other areas. People still have a desire to remain in control. It does not go away. It remains pretty strong throughout people's life, again, depending on what people's earlier function was. And the other kind of magic bullet that we have is music and rhythm. Now, in the IDD world, we already use this a lot, right? Because music and rhythm can be very helpful for people. It's very accessible. But with dementia, this is particularly helpful and it's evidence-based. What we find, and it's pretty much without, there really isn't a downside to it, is that music absolutely helps the brain reconnect between the left and the right quadrants. And so as much as possible, I recommend to people get music into people's days, get music and rhythm into people's days. And music and rhythm can also look like structure. If possible, even increase the structure in people's days, because that takes on that element of rhythm for people, the rhythm of the day. And by the way, it's the music that people liked earlier in life. Again, I have a person who was like, I play music and it doesn't do any good. And I said, well, what music are you playing? And she said, well, the music I like. And I say, okay, the music you like is maybe not going to be helpful. What music did the person like? Does the person like? So think about folk music, by the way, is almost always helpful. But country western for some people, spiritual music for some people is helpful. So think about how you can get the music and rhythm into people's days. Also pay attention to sensory impairment. Always check out vision and hearing if you see people's decline, because it could be sensory. For in the IDD world, maybe not so much the language of origin, but also, by the way, people will go back to their language of origin. One time I was working with a woman in the nursing home and they were all saying, she doesn't have language anymore. And it's like, because her English went away and now we had to learn some Russian to be able to communicate well with her. Do people already have psychiatric diagnoses? And one of the things that can happen with dementia is these can become more profound, particularly anxiety disorders. So if they've been able to manage those without medication all these years, it could be that when dementia starts to sit in, you really do need to kind of look at that and make sure that that's treated. The other issue is, here's what we do, and I have to say in the IDD world, we don't do this quite as significantly, but we still do as people get older. Someone fractures a hip, breaks an arm, has some sort of incident. We take them to the hospital. We put them under anesthesia, which in and of itself is a problem. We put them under anesthesia because it dehydrates the brain. They wake up in an odd place. We have people in and out of the room. We transfer them to a rehab setting. We move their room around 3 different times in the rehab setting. Now we have COVID, so nobody familiar can even see them in the rehab setting except through, Zoom. And then we send them home and we're surprised when they're significantly more confused. You know, like, so what I say is, you know, if you're seeing significant signs of decline, has there been a recent disruption? And again, I say that folks in the IDD world tend to be a little bit more tuned into this than folks outside IDD, because oftentimes we are trying to keep things well structured and predictable for people. I just put this slide in because we found that some of the practices, again, that we have for younger adults and children and adolescents in the IDD world, as people get older, whether they develop dementia or not, but particularly if they start to have dementia systems, may need to change our practices. And so some really common practices, we focus a lot, and it's good, at sensory stimulation and challenge. You know, we're the best at trying to figure out. But the problem is when folks develop dementia is sensory stimulation can be scary now. So really this balance of how much is too much. And some of those sensory practices that we would have done earlier for folks when they develop dementia become overwhelming. And so we got to kind of temper some of that down and really kind of look and see, is this precipitating behavior? Okay. Oops, it's already 11:30. I'm sorry. Let me just go through here real quick, and then you can read the rest of the, I'm sorry. We want to do novelty and exposure, but we need to move over to predictability and consistency. We want to do skill building and increased independence, but the problem is sometimes it's about maintaining, and again, this predictability, not pushing people out to be more independent, but to try and keep them where they're at and kind of increase that predictability. We want to do choices and opportunities. The problem is that for people with dementia, too many choices is harmful. So can we limit the choices? Normalization, again, we do all of these things, but the problem is that this, for people with dementia, is not really as helpful. Really what people need is kind of failure-free activities. They need to be able to do puzzles and things that aren't real frustrating to them. And then also we may need to really look for what is a supported living environment for this person at this age. And the supported living environments that we would have used earlier need to be changed, need to be a little bit different, need to probably be a little bit more predictable. Okay, I'm sorry I went over time. If you look at the rest of the slides, though, you can all download them. The rest of the slides, I'm just going to run through them. You know, getting to know individuals, you guys do that, but I put that in. Thinking about that, communication, thinking about your visual cueing. Again, you guys are doing that. It just may be doing it more. Sequencing is something that we don't often do in IDD quite as well, maybe with small children, but we really need to pay more attention to sequencing and kind of see how we can sequence. And then I put in lastly, and this is just kind of how we approach people and get into space. And this is called positive physical approach. And this is called hand under hand assistance. So your hand is actually under the person's hand supporting them. And then, so you have the other hand. This is what we call, so I just kind of put that in. Again, this is, you know, kind of evidence-based practice, which you may or may not already be using, or your staff may not. If you want to really see this demonstrated well, go on to positiveapproachtocare.org. This is a great website. Teepa Snow is the occupational therapist that has championed this, and they just have lots of good examples or videos that kind of, you know, show these practices. The Alzheimer's Association also has lots of good material. Their website's a little difficult to navigate. And then the National Task Force on Dementia and Intellectual Disabilities has a ton of wonderful resources on their websites. So I'm sorry, Kristen, I went over time. I'm going to stop sharing this and you can introduce the next speaker.
Oh, well, thank you. Paul, I can't thank you enough for your knowledge and all the information that you shared with us today. I'll
stay on if anybody has any questions after your other speaker.
Okay.
But my email is also on there. People can always email me.
Okay, fantastic. Our next presenter is Ashley Norris, and Ashley is going to talk to all of you about Rhythm and You. Again, if you have any questions, please feel free to speak out and ask Ashley. So welcome, Ashley. Thank you for joining us today.
No problem. Thanks for having me. Hopefully you guys can hear me okay. Okay, let me know if I need to do anything. I'll just start talking and
Okay.
hopefully leave room for questions at the end. Let's see here. Okay, so I think I